Hello everyone, welcome to the case-based learning session. In this session, I got a very interesting case for you which we managed in our ICU, but unfortunately the patient succumbed to death, but we learned a lot from this case. So the case was a 65-year-old male. He was living in an old age home. He was brought to the emergency department with complaints of a decreased level of sensorium for last 5 days. So the history was like this. For last 5 days he has been kind of lethargic, tired. He has not been taking enough food and water, and last 2 days his sensorium really worsened. Now he's not able to get up from the bed. He's not responding at all. He's really obtunded. And in the emergency department, his vitals were, he had a heart rate of around 130 per minute. It was sinus tachycardia. He had a respiratory rate of around 29 per minute. And his blood pressure was on the lower side. He was hypotensive with a BP of only 80 over 40 millimeter of mercury. So we traced him to the red area, we connected him to the monitor, we got 2 large bore IV lines, we got our point of care ultrasound machine there, we looked at the IVC, it was collapsing. So we gave him a bolus of around 1 to 2 liters of normal saline, and with that his blood pressure actually somewhat came up. The tachycardia was coming down, blood pressure was improving, but his sensorium was still on the lower side. Okay, he was kind of maintaining his airway, but we could hear the snoring part. So we inserted a nasopharyngeal airway in, and that cleared the airway for the time being. All right. So we got a 65-year-old male living in an old age home, and who has had progressive deterioration in sensorium, now coming with tachycardia and hypotension. The features of shock is there. Alright, so we had to consider all the differential diagnosis of his shock. Alright, now moving on with the further history, he had a past history of psychiatric illness for last 5 years, for which he was on medication. He was a diabetic as well as hypertensive patient as well. Alright, he was on insulin and metformin for his diabetes. He was on anapril 40 milligram per day for his blood pressure, and atenolol 100 milligram per day. Alright. Then for his psychiatric illness, it was a bipolar disorder. He was on lithium carbonate 600 milligram per day. Okay. And he was also on thyroxine 50 microgram per day. Alright. So with these findings, patient coming with shock, possibly a hypovolemic shock, we still had to suspect a sepsis here. But the patient was fluid responsive, it was less likely to be into a phase of septic shock. We still kept the possibility of sepsis here, elderly male, diabetic, coming with decreased responsiveness. Alright, it could be even a neuroinfection or any other sites of infection. Other possibilities that we considered here was a myxedema coma, considering that he was having hypothyroidism. We didn't know whether the patient was compliant with his medications. Alright, so that was also one of the things in our mind. Then one of the more common things, hyponatremia or metabolic encephalopathy here. Okay, so and because he was a psychiatric patient on lithium, of course lithium toxicity has to be in our list, right? Okay. By now, most of you must have realized that this is a case of lithium toxicity. Of course, this is a case-based learning session on toxicology, and we got lithium here, right? Alright. Okay, now let's talk a little bit about lithium. Lithium is one of the most favorite drugs of psychiatrists for bipolar disorders, especially to control the manic episodes in bipolar disorders. But I'm telling you, for an emergency physician and ICU physician, it is one of the worst drugs to be presenting with toxic features. Right. Okay. Now, the exact mechanism of action as well as the mechanism of toxicity of lithium is not known. There are a lot of theories out there, and one of the theories which you need to know is that it decreases the level of inositol. So it decreases inositol intracellular level. I'm not sure what's the implication of that, but this is one of the theories. Okay, then it messes up with a lot of other neurotransmitters like serotonin, dopamine, and norepinephrine. Alright, my biggest concern here is because it increases the level of serotonin in the brain as well as in the body. Okay, now if the patient is already on some kind of SSRI or a MAO inhibitor, lithium has the potential to cause serotonin syndrome. So that's one concern I have. Alright, now the other big headache with lithium is that it interferes with all the other electrolytes in our body. It interferes with sodium, potassium, calcium, as well as magnesium. Now the problem here is that whenever lithium interferes with sodium channels as well as the sodium potassium ATPase pump, it inhibits these two channels. It does this function in the myocyte, it can result in arrhythmias. Okay, so sodium and sodium potassium ATPase inhibition. Myocyte, it can cause arrhythmia. Not good, right? It can also decrease your cardiac output by a negative inotropic action. Okay, so decreases cardiac output. Alright, now the other thing we need to know is that in the kidneys, it can produce nephrogenic diabetes insipidus. So it inhibits the action of ADH on the kidneys and causes nephrogenic diabetes insipidus. Alright, so nephrogenic diabetes insipidus. Alright, okay. Now, in chronic patients, it is a neurotoxin as well. Okay, so in chronic lithium taking patients, it is a neurotoxin. Okay, now the other important thing to know about lithium is that it has a very narrow therapeutic index. Alright, the therapeutic index is between 0.6 to 1.2 milliequivalents per liter then. Okay, so a very narrow therapeutic range. Any value less than, any blood level less than 0.6 is not going to be effective for the patient's psychiatric condition, and any level more than 1.2, to be more specific, more than 1.5 has the potential to result in toxicity. So a very narrow level is there for the therapy. Alright, so narrow therapeutic index. Now another important thing is that I know I keep on saying so many important things are there because they are important. Okay, now one more important thing we need to know is that the half-life of lithium in young adults itself is going to be 18 to 24 hours. Now if somebody is taking lithium for a long time, especially elderly patients, it can prolong to up to 60 hours. So if you are planning to wait and watch, so that you might expect the symptoms might settle down by just supportive care, you might have to wait for a long time. Alright, now next most important thing to know is that elimination of lithium is just like sodium from the body. Alright, so it eliminates through the kidneys and it gets reabsorbed from the proximal convoluted tubule. Okay, so elimination through kidneys and reabsorbs from proximal convoluted tubule. Now the importance of this is that whenever there is hyponatremia, it could be because of any reason. It could be because of diuretics, it could be because of decreased salt intake. Then in all those conditions, what's going to happen is that there will be hyponatremia, and the body and the kidneys especially cannot distinguish between lithium and sodium. So it tries to preserve sodium, and instead of sodium it will reabsorb more of lithium into the body. Alright, that's one problem. Now whenever there is renal insufficiency, renal elimination of lithium also get affected. So even if the patient has been taking a regular dose of lithium for a long time, a decrease in the renal function can precipitate renal toxicity. So these are some of the implications, the pharmacokinetics, that we need to be familiar with. Alright, okay, now let's move on to the clinical presentation of lithium toxicity. Now our patient has been on lithium for last 5 years. So he's a chronic patient. Now what could be the reason that precipitated his toxicity? If it is lithium toxicity, first of all, it could still be sepsis, it could still be hyponatremia or any other electrolyte abnormality. It could still be hypothyroidism or myxedema coma here. So how did we rule out? Can it be a cerebrovascular accident? It could very well be, right? So in this patient, what we did was, okay, we did the blood samples, alright, and hemoglobin we got as 12.5, total count was normal, platelet was normal. We did blood cultures and multiple times, and all of them were negative. Okay, the patient didn't have any features of fever, there was no focus of infection, and the blood cultures were negative. So sepsis was kind of on the lower side of our priority list. Okay, now the patient's TSH was also normal. So essentially it ruled out myxedema coma here. Okay, we did a CT scan for the patient. It did not show any infarct or any bleeds. Alright, so CVA was also less likely. The patient didn't have any focal neurological deficits as well. Alright, so that puts lithium toxicity high in our priority. Now how do we confirm that? So we did a serum lithium level. Alright, and what was the result? The serum lithium level was 2.9 millimoles per liter or milliequivalents per liter. Both are same here. Okay, so what was the normal therapeutic range? It was between 0.6 to 1.2 millimole per liter. Now here it's very much elevated. So is this severely elevated to cause the symptoms here? Yes. Okay, now let's see what are the clinical features that any patient could present with in a case of lithium toxicity. Now the clinical features, based on the clinical features, the patient can have acute toxicity, chronic toxicity, or even acute on chronic toxicity. Now acute toxicity, okay, it usually results from an intentional or accidental ingestion of lithium tablets. Okay, so the patient who has not been on lithium for a long time, now he has taken lithium. Or the patient might have a new psychiatric illness for which lithium has been started now. Okay, it can manifest even within a few days of starting the medication. Alright, now in acute toxicity, most of the symptoms are going to be GI manifestations. The patient can have nausea, vomiting, diarrhea. Patient may have abdominal pain as well. So predominantly GI symptoms. Why the GI symptoms happen is because lithium is also a metallic salt. Like any metallic salt, it can cause GI irritation. Okay, it is kind of a corrosive as well. So the mucosal, there can be a lot of mucosal injury in the intestine, which can result in nausea, vomiting, diarrhea. Alright, okay. Now these patients can also have late neurological manifestations. So usually they present to the emergency department with GI symptoms, but they can have late neurological manifestations which usually takes a few days to manifest. Okay, so the neurological manifestations can include confusion, lethargy, sometimes tremor, and in severe cases, patient can have seizures and even coma. Okay, it's very serious. All right. Now, in chronic toxicity, all right, chronic toxicity, these patients are more likely to have neurological manifestations. Neurological manifestations. like worsening of tremor, they could be having dysarthria, they could have ataxia, they could be lethargic, confused, those kind of things. And then again, in severe cases, of course, seizures and coma are a possibility. Alright, now one thing to remember is that there is this entity called silent, which can manifest in patients with chronic lithium therapy. Alright, now silent is for syndrome of irreversible lithium effectuated neurotoxicity. Okay, let me just write that down. Syndrome of irreversible